All right. Well, it is 12:15, so let's go ahead and get started. Thank you all for being here. I'm Ildi Martanfi, and I'm not Serena Schrager. Like the flyer said, Serena had another obligation that she could not switch. So it's my pleasure to introduce Dr. Rudin, and then hopefully we'll have some time for questions as well, and I'll be able to help us facilitate those. For those of you who don't know Dr. Rudin, he specializes in pain medicine with a rehabilitative approach here with UW. His practice primarily focuses on the diagnosis and management of chronic pain, and he has great expertise and interest in hypermobility disorders such as Ehlers-Danlos. He teaches locally and regionally and nationally on all sorts of topics and does some wonderful research. And from the patients that we have shared, I will say he's a phenomenal colleague and compassionate physician as well. So without further ado, Dr. Rudin, we are thrilled to have you here.
Thank you so much, and thank you for being here, everybody. I appreciate the invitation and the chance to speak with you. I'm going to put up my slides. Let's make sure that they are showing. Are you able to see them okay? All right.
We are.
Yes.
All right. And you're able to hear me okay? All right, because Webex is giving me some interesting messages. All right. Let me get this window the heck out of the way so I can do this properly. All right. So wanted to talk about hypermobile patients because, as anybody in family medicine knows, they're all over the place. And my hope was to spend some time chatting about them and how best to help them and what some of the special considerations are. I don't have any relevant financial or corporate interests or relationships, or for that matter, financial acumen. Any uncredited images in the presentation are my own, and we do refer to the diagnostic criteria from the Ehlers-Danlos Society for EDS. We also talk about the consensus guideline that we put together through Center for Clinical Knowledge Management, and that's copyrighted by UW Health. We do talk briefly about off-label medications as well. So what I'm hoping to help you do is be able to recognize and diagnose patients with hypermobility spectrum disorders, at least to get the idea and the suspicion that that's going on with these patients, help you with prescribing initial treatments and self-management tools for these individuals, and help you be more able to evaluate and appropriately address some of the comorbid conditions, either personally or through specialty referral. Now, I do have a QR here. It's always tricky when you're doing a WebEx to figure out, will you be able to use this thing or not? We have a survey that we've been asking primary care providers to complete to share your knowledge of hypermobility conditions and their management. And if you already completed a few months ago when the notice went out, please do it again if you would after the lecture. I've got the link down at the bottom as well as the QR code here. If you have never taken the survey, please do so. Again, we'll put the slide back up at the end. I'm trying to get a sense of how our clinical guideline and accompanying EPIC pathway have worked in helping you folks bolster your knowledge. Okay. So into your clinic comes a young to middle-aged person. That's the most common. More often, yeah, we can definitely put the link in the chat at the end of the talk. I will take care of that by all means. A young to middle-aged person, they are more often female, who comes in with complaints of chronic joint and muscle pain and chronic fatigue. And these folks report joint subluxations and clicking and popping and maybe even things dislocating. They may roll their ankles a lot or sprain their ankles. They may have back pain and neck pain. They may have scoliosis. Anterior knee pain is pretty common. It's sort of a patellofemoral pattern. They may have a history of knee ligamentous injuries. They may have TMJ dysfunction and pain. There may be popping and locking in the hips. And these are people who generally have been all over the healthcare system. They've been bouncing everywhere. Unless you're lucky enough to catch them early and be able to start working on them before the bouncing begins. A lot of them have already been to a zillion specialists, and they may carry various diagnoses. Well, you got pain all over, you've got fibromyalgia, or you've got mixed connective tissue disease. I'm still kind of trying to figure out what that is. Or you may have seronegative rheumatoid arthritis. You don't really look like it, but you have a couple of positive markers and your joints hurt, so we're going to call it that. They've been absolutely all over the place, but they may bring you a history of unusual joint flexibility. And if they don't tell you about it, it's quite a good idea to ask about it. You know, historically, these folks have all kinds of things going on, you know, pain and tenderness. They may have orthostatic symptoms, lightheadedness, syncope or near syncope. Tachycardia can be common. And even in anxious people, they will say, when I'm not anxious, I still get tachycardic anyway, which of course makes me more anxious. Constipation and diarrhea are pretty common, as are abdominal pain, bloating, and nausea. Lots of headaches. Migraine headaches, tension type headaches are most common. Anxiety, depression, and ADHD are common in this population. And some of them will report odd flushing, rashes, and swelling that don't seem to have clear provocations. It's not the sort of thing where you know they're allergic to something and that makes them swell up and itch. They'll swell up and itch sometimes for no reason at all. So a perplexing bunch of individuals. But what we want to try to get you doing is asking, when you see a person like this, could this patient have an inherited hypermobility disorder? Because that constellation of symptoms, that gestalt, if you get enough practice in it, you sort of can start to see them coming. And it's important because, first of all, hypermobility can affect lots of aspects of medical and surgical care. Surgeons have to worry about tissue closure, making sure everything is held together properly, and other issues. And hypermobility is really common, but it's not often recognized, as we'll talk about. You know, if you're like me, you were not taught to treat things like hypermobility and Ehlers-Danlos syndrome when you were in medical school. In fact, they said, hey, EDS is rare. You're not going to run into this very often. And if you do, send them to genetics. And it turns out that patients wait an average of more than 10 years for diagnosis, ordinarily. I get people who come in and say, you know, I've been waiting 18 years for somebody to finally be willing to make a diagnosis for me. And we're mostly dealing with the Ehlers-Danlos syndromes. Now, in general, most of these are rare. This is a heterogeneous group of heritable connective tissue disorders. And they have three things in common: hypermobile joints, fragile tissue, hyperextensible skin. They've all got those things to varying degrees, and that's the only thing they have in common because they're totally biochemically different conditions. They're all distinct. Some of them are disorders of collagen, but many of them are not. And there are, at last count, 14 defined types, and 13 of them are pretty rare. You've got classical and vascular, the second and third most common types. Classical at 1 to between 20 and 40,000, vascular 1 in 100 to 200,000. And all the rest of them are either quite rare or ultra rare, around 1 in a million. So you're not going to see them very much, but hypermobile type may be as much as 1 in 500 people, which was the prevalence seen in a recent study done in Wales. And whereas before they were talking 1 in 10,000, 1 in 5,000, the numbers have slowly been increasing as we've learned more about the population. And hypermobility itself without symptoms may be present in as much as 10% of the population. So being stretchy is not an uncommon thing at all. Ehlers-Danlos syndrome, we think, is autosomal dominant inherited, but it is the one EDS where we don't know what the gene actually is. So the prevalence is high. The morbidity is somewhat less than in the other Ehlers-Danlos syndromes. Vascular EDS can kill you. You can blow out a big aneurysm or something like that. And many of the others can cause very, very severe deformity and joint problems. The morbidity, though, can still be significant. We've got a pretty significant range, everywhere from people who are functioning well, getting by in life, but having some problems, to people who are practically immobile and not able to work. Hypermobile EDS doesn't seem to alter fertility, but early labor can be possible, and there are some other increased risks that we'll talk about with pregnancy. It doesn't generally shorten the lifespan itself. And the molecular basis is unknown, so we really don't know what the genetic underpinnings are, although there are finally some markers coming under investigation. There's a preprint circulating widely on the net right now because it got leaked before the lab could publish it. So they threw their preprint out there. They're looking at the kallikrein enzyme family, which you may remember from way back in med school as part of the clotting cascade, and also kallikreins help to create bradykinin, which is a pain neurotransmitter. That's a family of serine proteases. What the heck did they have to do with being stretchy? We don't know yet, but we do know that if you put the mutation they found into mice, you get stretchy mice. So we could be on something. And stretchy mice would be a great name for a band, but that's another story entirely. So anyhow, just to make life confusing, there are also these so-called hypermobility spectrum disorders, or HSDs. These were defined in the most recent criteria for the Ehlers-Danlos syndromes, which were done in 2017. There's a new set due in 2026. And so people with the HSDs don't quite meet hypermobile EDS criteria. They have a bit less baggage, fewer non-articular features. People with generalized HSD still can have a high Baton score, but they don't quite tick all the boxes in the criteria. And we'll talk about that more later because it turns out to be very squishy, trying to figure out who do you call hypermobile EDS and who don't you? And does it really matter? Oddly enough, though, if you take the people with the HSDs, the inheritance pattern, the comorbidities, and the treatment are the same. And if you look at the dermal fibroblasts and the extracellular matrix, they look the same. So it's probably the same conditions with different points on a spectrum. And hypermobile EDS is probably not one genetic entity anyway. It's probably a bucket with a bunch of different things in it that we haven't been able to classify and separate out yet. So ultimately, labels are going to change, diagnostic techniques are going to change as we keep going. Okay. So that diagnostic odyssey I was talking about, the average time to diagnosis in a 2023 study was 10.4 years. People will come in and they will tell you long stories about being told that they're crazy, about being told that this is all in their head, about being told that they have growing pains, despite the fact that many of them are already skeletally mature, or when they stop their growth spurt during their teen years, the pain is still there, even though the growing has stopped. And there will be people who are told, I think you have hypermobile EDS, but I'm not going to say so. I'm not a geneticist. Thing is, you don't have to be a geneticist. And in fact, the geneticists got so swamped with referrals for this condition that they said, it doesn't have a known genetic cause, and we advise and counsel more than treat. So why don't you go see Rudin, which is how I got so busy in the first place. But these folks find it tremendously validating when they finally are diagnosed, because then they've got something medical they can wrap their heads around, and that the healthcare system can wrap its head around to help them feel better. Now, back at good old Johns Hopkins in Baltimore, this is the old Hopkins Hospital. We were told that the EDSs are rare, but once we get to that 1 in 500 number, suddenly things look different. So why the heck is this family medicine's problem anyway? I mean, don't you have enough to do already? We all certainly do. But the fact is, this is a really common condition. We have 6 million people in Wisconsin. At 1 in 500, that's an estimated 12,000 people in Wisconsin with hypermobile EDS alone. And it's an underserved group. There are fewer than 5 EDS physicians in Wisconsin, and at least a couple of them are running pretty much boutique clinics. They will see you and do a lengthy evaluation and a diagnosis, but it's cash up front and they don't take insurance. So there are a couple of practices out there that will do this service for people, but the access is very tight. Meanwhile, there are about 6,000 primary care providers in Wisconsin. So, and my hope is to convince you that this is a relatively easy thing to diagnose because it is, we don't have a test. It's entirely clinically based. It's your H&P. Who's better at taking a good H&P than a family physician? So you've got the tools. We want to expand that toolbox to help you. And we are making the same pitch to internists, to rehabilitation physicians, to lots of people who see folks with this constellation. Because it's incredibly common, and these people really need help in order to improve their quality of life, and as well, hopefully, to decrease their draw on the healthcare system with all the redundant visits and rushing from specialist to specialist. Primary care doctors also are able, and other providers are able to start effective treatment. And these are common conditions that cause significant impairment and disability. So my goal really is to enable you folks to recognize and diagnose and begin treatment for people with these conditions in the medical home, with the understanding that if it's not working, yeah, we specialists are still here and willing and able and ready to help. Okay. So there is this set of international consensus criteria that were developed and published in 2017 through the Ehlers-Danlos Society, which is an international group headquartered in the UK. These criteria are supplemented by a detailed history and a focused examination, and they can be found easily at the ehlersdanlos.com website. We'll talk some more about them later. I'm not going to take the time today to go into all of them in great detail. They're fairly self-explanatory, but if the criteria aren't met, you would call it an HSD unless you suspect that something else is going on. For example, if there were clues in the history to suggest an aortopathy, something like a vascular EDS or a Marfan syndrome. If you can't figure out what the heck it is, sometimes a genetic referral is helpful, particularly if you're worried about a potentially dangerous condition. We'll come back to the criteria and how to apply them in a little bit. During the history, some of the other things I like to ask people are, do you use braces or splints at all? And people will say, oh yeah, I got a brace for my knee and a brace for my ankle and a brace for my wrist. These are often people who, when they are younger, have a real affinity for gymnastics and sports and dance and martial arts and swimming, things that push their bodies to the limit. And I figure that's because if you never feel like you can get a good stretch, you're going to want to do things that really get those proprioceptive nerve endings working. They get you feeling like you're working that body. And so they're very, very active until they're not, because their joints begin to dislocate or sublux, or they get sprains or strains or other injuries. The body eventually says, wait a minute, I'm getting tired of this. They may have chronic musculoskeletal pain, chronic fatigue. They frequently demonstrate Raynaud phenomenon. They may have headaches. There's a lot of stuff you can see. Many of them will tell you about TMJ problems from a loose TMJ, but also, and this is poorly documented in the literature, gum and tooth problems are really common in this population. Everything from weird root development to early caries for no good reason. They also, many of them will have troubles with an overly tight pelvic floor. Overly loose can happen, and you might expect that with this population, but overly tight can happen as well, because when your joints and ligaments don't hold you together when you stand up, you try to hang on whatever you can to support you. So people tend to hang on their fascia, their thoracolumbar fascia, their iliotibial bands, and they will over-tighten midline structures to try to keep them upright. And the two most notorious spots are smack between the shoulder blades and the pelvic floor. So you get a lot of people with dyspareunia, with overflow incontinence because they have trouble getting the urine out in the first place, and with pelvic floor pain. Hypothyroidism, particularly after Hashimoto's thyroiditis, is pretty common. So is polycystic ovarian syndrome. GI complaints are frequent, as we talked about. They may report unusual scars, delayed healing, easy bruising. We talked about the flushing and urticaria stuff. They'll come in and say, hey, do I have mast cell activation syndrome? And if you're like me, when I first heard it, I said, I have no idea what that is. They may have postural lightheadedness, tachycardia, and syncope. They may come in and say, you know, it's really weird, but I need to drink water all the time. And if you ask them, many of them really like to eat salt. One patient said, how do you know? That's just bizarre. Yeah, I actually drink pickle juice out of the jar. I do have a small pickle juice club, as well as people who, because of the orthostatic symptoms, they discover without knowing why that they really like compressive garments. I've had people come in and say, Doc, you're going to think I'm nuts, but I don't really feel good unless I have spandex under my clothes. And I feel much better and much more alert and less tired. And I say, okay, either you're a superhero or you have this problem. So looking at hypermobility, the main scoring measure that is used in the international criteria is the Baton scoring system, which is a 9-point scale. You've got to measure hypermobility at 9 sites, 4 bilateral, which makes 8, and then 1 unilateral. And it's pretty straightforward. First of all, you put the hand down on the table. Can you get the pinky at the MCP to 90 degrees or more? That's 1 point per hand. Then, with the arm up straight and the palm down, can you get the thumb to touch the flexor forearm? If you can, that's 1 point per hand. Now, some patients can actually do it the other way, and you have to correct them. No, do it this way. It depends on how mobile they are. Next off, the elbows. Do they extend beyond 10 degrees past normal neutral? You may need a little goniometer to figure that out. That's 1 point per side. When they're standing up, if you have them lock their knees backward, can they hyperextend more than 10 degrees? And if yes, that's 1 point per side. And lastly, if they bend forward at the waist with their knees straight, can they get their hands flat on the floor? That's the 9th point. So the maximum is 9, and the cutoffs in the criteria are 6 or more for prepubertal children and adolescents, 5 or more for men and women to age 50, and 4 or more for men or women over age 50. And then there's a set of questions you can ask, and if they answer yes to 2 or more of those, they get an extra point. So you'll notice that they have a cutoff for prepubertal children and adolescents. That's interesting because there are some people who will say, I will not diagnose anybody who's not skeletally mature with hypermobile EDS. It's not at all clear that you need to wait that long. There remains controversy over diagnosing it in kids, but frankly, there are some children who, once they get to be 9, 10, 11, they're floppy enough that you can kind of know, especially if you're used to examining children and you know where their joint ranges usually are. More flexibility is pretty normal in young children, but maybe not to this degree. And if they fit all of the other criteria, you may wish to think about, at least provisionally, making the diagnosis in order to help get them into treatment. Other joints you might check are these. So the toes, do the big toes hyperextend? Do the IP joints of the toes hyperextend? Is there increased ankle motion? When the patellae, when the people are supine on the table and their quads are relaxed, are their patellae really mobile? Do they slide all over the place? Can they do unusual things with their hips? More rotation than normal, more abduction than normal? What about their shoulders? If you put a hand on the shoulder and stabilize the scapula and you grab the humeral head, can you slide it back and forth more than you should be able to? Can people tuck their hands behind their backs and get their fingertips all the way up to C7? Those are all tips that there's more motion than there ought to be. And then there are a lot of other things you can look for as part of building your gestalt. Hyperextensible skin, it's not usually as extensible as it is on this individual for hypermobile EDS, but some people do have it. Translucent skin is common. Raynaud phenomenon is common. You can see the purple and white there on that third picture, and that's one of my people who can actually bend the wrist back the other way. And pisogenic papules, which are little heel bumps that appear when you are standing. That's the normal fat under the heel fascia poking through in places. Most people don't know they have them because who the heck looks at the back of their heels when they're standing? But those too can be a clue. And a few other things, long fingers, arachnodactyly, where they can actually, for example, put their thumb and pinky together, have it meet around the wrist and overlap by a knuckle. Flexible flat feet. Unusual scars, that's an atrophic scar I had on one patient who had a total knee. And easy bruising, people have bruises that they have absolutely no idea where they came from and that can be larger than one might expect from a minor blow. So there's all that stuff. So how do you put it all together in a way that makes it work? We did build a consensus guideline. I put together a work group, including a couple of physicians from your department, with the purpose of laying out a basic structure for initial diagnosis and management to these individuals. And I built this with Lee Skrupke of the Center for Clinical Knowledge Management. And the target population is basically from adolescents up, from about 12 years up, to give you standardized and evidence-based guidelines for the evaluation and initial management of these conditions. And there is a whole flow diagram in the guideline. You can find this thing in the Pulse. All you have to do is search on Ehlers-Danlos guideline. There were two documents. There's the full guideline, and then there's an executive summary, which abbreviates it. So it goes through all the various comorbidities and talks about what to do when you're first looking at these people. A number of you have already contacted me and told me that they're using this pathway, which is wonderful, and trying to figure out what you do with the fine points. For example, what happens when the diagnosis isn't as clear as we would like it to be. So anybody who's a healthcare professional or representative of a healthcare system can get a hold of this thing. We don't recommend distributing it to patients, not at this time at least. UW Health has it copyrighted, and they're happy to distribute it to the health systems, but don't want it to be complete patient gospel at this time, especially with the criteria getting ready to be revised again next year, at which point we'll be revising the guideline again. So you can search the Pulse for it if you are a UW Health physician. If you are external to UW Health, you go to the uwhealth.org standard website and you search on these terms. in turn, and you'll be able to pull up the document. If you work at UW Health and you are doing an ambulatory encounter, you also can go to the Pathways tab. If you haven't seen it, well, we just had our update today. Notice I haven't said upgrade because the jury is still out. And you can ask them, hey, where's the Pathways tab? If you click on that and select Ehlers-Danlos, you'll get a whole flow chart. This is the beginning of it. That puts that whole flow diagram from the guideline in Epic and allows you to click on various reference materials and order all the various orders that you're looking for. So it makes it easier to make all this go. We've even got links to the medications we might recommend with dosing recommendations included. So there's lots there to try to make it easier for you to do this work. And, once you get through the pathway, what do? Well, for diagnostic support, the pathway says you can order an adult pain e-consult with the term Ehlers-Danlos in it. That will wind up with me, and I will try to help you figure it out. At this point, the toughest part is if diagnostic support requires a visit with me, those are pretty darn scarce at this point. I'm trying to figure out what I'm going to do with that, while at the same time continuing to make myself as available as I can through the e-consults. And I'm trying to keep some flexibility in the clinic template to allow people to come in for additional consults. Right now, just, out of the box, if you order a consult for somebody to see me for EDS, I'm backed up 600 patients, which is why it takes so long to get in. It is literally up to 2 years, which I don't find acceptable, but you can understand why I'm trying to get your help here. Anybody with a new diagnosis of one of these hypermobility disorders, get them to physical therapy. Our physical therapists, a number of them are very literate in managing these conditions, and you can ask for somebody who is specifically skilled in it in your consult. For people who have pain or weakness or instability in the upper limbs or trouble with their ADLs, an OT consult can be useful, and our OTs have become quite well versed in dealing with this population as well. If folks have foot or ankle instability, large joint instability, spinal instability, orthotics may be helpful. Unfortunately, custom foot orthotics are not available for Medicaid or Medicare patients because they've really limited who they'll give those to. So those people have to get off-the-shelf inserts. But custom orthotics can be very helpful in general. A lot of people with ankle stability, a good pair of foot orthotics with a deep heel cup to kind of capture that hindfoot will reduce ankle sprains and rolls while at the same time keeping people more comfortable and more stable. For people who are having trouble with coping and pacing and the behavioral aspects of chronic pain, which is, an awful lot of people with pain in general, not just these folks, you can consult health psychology to get some help both with individual and group interventions. And then for people who have orthostatic intolerance, we'll be looking at the chat in a little bit. With people with orthostatic intolerance, tachycardia, or syncope, you can send adults to the Faint and Fall Clinic through cardiology, at least for diagnostic advice and initial management steps. It would be a cardiology consult at Northern Illinois. And then there are specific consults for pediatrics as well at both locations. And we have links to all of those in our Epic pathway. I think somebody is unmuted. Might want to double check that. Okay. So how do you differentiate hypermobile EDS from the HSDs? I find it very blurry because you'll take people through the criteria. They are clearly hypermobile, but they might just miss the criteria. First of all, criterion 2A, where there were these 12 things listed and they have to have 5 or more, you get a lot of people who have 4. And then you're going, all right, what do I do now? And then you get a lot of people with the family history issue as well, because the criteria state first-degree relatives who are hypermobile and who independently meet the diagnostic criteria. Well, if your patient is the first person in the family to come into the doctor's office to get evaluated, if you take this literally, you can never diagnose them because nobody else in the family has had it done. So it is a self-defeating criterion. So if people tell me, well, mom can put her feet behind her head, or, you know, my sister can dislocate her shoulder or things like that, I say, okay, I'm going to give you the point. I give it to them. Has anybody screamed at me yet for being imprecise? No. If everything else really, really looks like it, and they've got a family history of stretchy people, I count it. If they are hypermobile at other bodily sites, but the Baton is really low, I usually go with the hypermobility spectrum disorder diagnosis. I want to see that Baton up there. I'm hoping that that will be reinterpreted in the next set of criteria, though, because the Baton only checks mobility at 5 body areas, 4 of them bilateral, but it misses shoulders and hips and patellae and ankles and toes and all kinds of other things where people can be hypermobile. If you have an adopted person whose family history is unknown, but they otherwise look good, I say, okay, we're not going to penalize you for that. We're going to give you the diagnosis if you meet it. If they have very elastic skin or periarticular nodules, what they call subcutaneous spheroids, or extensive family histories of aneurysm, or they have a marfanoid habitus plus an abnormal echo, I'm going to defer diagnosis and get them to genetics. And if the echo is very abnormal, you know, aortic root dilatation or aneurysms or major valvular insufficiency, I'll get them to cardiology as well. If the Baton is 1 point below the criteria, but the patient says, yeah, you know, I broke that elbow and it doesn't hyperextend anymore, but it used to, I give it to him. So there are places where if you stand too tightly on ceremony and don't diagnose somebody, you know, if they otherwise very clearly have it, you're doing the patient a disservice. It's a matter of how comfortable we are with these criteria and how, pun intended, elastic we want our interpretation of them to be. And it is tricky by all means. But sometimes I have to step back and say, okay, I have all these data in front of me. My gut says this, that's probably it. And yeah, if you have a question about it, please ask me. What about people who need special workup? There are a few things that come up that patients ask you about, and you'll scratch your head, you know, like mast cell activation syndrome. Do I have mast cell activation syndrome? You don't know, right? This is not your wheelhouse. I say, well, let's find out what your symptoms are. So the diagnostic criteria for mast cell activation syndrome from an article in 2024 are actually here. These are derived from a consensus group's work. And they say, you know, we're talking severe recurrent systemic mast cell activation like anaphylaxis and edema. And they have an elevated tryptase, and they may have other elevated markers. And they respond to antihistamines and montelukast and drugs like that. So this may not be a workup that you want to be messing with. But what we found is that the poor allergists are so busy that they say, all right, start the workup, and if it's positive, we'll see them for it. But that means ordering a tryptase and 3 24-hour urine tests. It's all in one 24-hour urine, which the patient has to do when they are off all antihistamines and in the middle of a symptom flare. So it's a tricky thing to capture. So if you're thinking about referring to allergy, call and ask them, hey, what do you need? And they will tell you. But then you have to be frank with the patient. Sometimes I'll just start them on famotidine and cetirizine to get the H2 and H1 receptors in turn and see if they feel better, if they're having major league mast cell type symptoms. People will ask about Arnold-Chiari malformation, which does have a somewhat increased incidence in this population, although generally not severe. If they have a refractory headache, along with hyperreflexia, particularly if you see a Babinski sign, you might think about an MRI of the head. The vast majority of times we look, we don't find a Chiari. People ask a lot about craniocervical instability. That is a pretty rare finding in people with EDS. It can happen. It can cause symptoms because of loose ligaments in the upper cervical spine. The problem is it's really, really hard to diagnose. And what's the treatment? Occipital to C3 fusions are not nice. And really the only definitive treatment of instability is to operate. So unless people are seriously unstable up there, we don't do that. So if neurologically they're clean, and if we do this set of cervical spine x-rays and it looks okay, we leave them alone. And the Z-spine x-rays, we're talking AP lateral, flexion, and extension, but also they do an open mouth view and they have them tilt the head left and right. So they look at what the lateral masses are doing at C1, C2. And some people will have a tiny, tiny bit of laxity there, but generally people have normal studies. Even if they're not, you can find out other things like, there may not be instability, but their cervical spine may be pulled very tight and straight by spasm, or there may be degenerative changes that you hadn't known were there. If you suspect POTS, postural orthostatic tachycardia syndrome, or vasovagal syncope, cardiology consults can be helpful there. So we don't really expect you to try to manage all this stuff yourselves, but I'm giving you the initial diagnostic steps in case you want to take a look, particularly if the wait to see a specialist is long, but also if your clinical suspicions are aroused. You don't have to order all this stuff just because people ask for it. You order it if you think it's clinically indicated. And if you wind up with a situation where it's insoluble, the patient is insistent and you're not quite sure what direction to go in, that's where the appropriate specialist can be helpful. In pregnancy, well, they used to say that hypermobile EDS wasn't a huge problem with pregnancy, but it certainly can be. Not as bad as with vascular and some of the others. We do strongly suggest that maternal fetal medicine be involved for people with hypermobile EDS and the HSDs because most of the pregnancies are still uncomplicated, but there is a higher risk than normal of complications. Now, hypermobile EDS itself, we don't think directly affects conception, but back and sacroiliac joint pain are common. They may require PT attention. One thing you can do is send them to orthotics, get a sacroiliac belt to help hold the pelvis together, and that sometimes is very helpful. POTS may get worse early on in pregnancy, but often in the second and third trimesters gets better because the blood volume has gone up so much. Every once in a while, you'll get somebody who needs bed rest. I've only had 1 or 2 people who needed to get saline infusions a couple times a week. That is very, very unusual. Most people do pretty well. But there was a recent review published looking at a risk of pregnancy complications in the hypermobile EDS versus non-hypermobile population. They looked at about 1,200 patients. And the risk of preterm birth was about double compared to normal, rapid labor more than double, prom greater than normal as well, preeclampsia and eclampsia elevated, hemorrhage risk 2 to 3 times normal, hyperemesis gravidarum a lot higher, and shoulder dystocia in the kid way higher. You might expect that. PTSD after birth also higher in a population at baseline, probably has more anxiety than normal. Okay, just a couple of other things. In PT, PT's pretty much standard of care for everybody who's been diagnosed with this condition. At the beginning, you need to start very basic with the complex cases, but we work on motor control, stabilizing the trunk, getting their proprioception better so they're not falling all the time, light aerobics, and they may need some manual therapy. They'll talk about ribs popping out. They'll talk about sacroiliac pain. And we get them progressing gradually to independent exercise and self-management. The goal of these folks is really to give them as many tools as you can, because we want them managing themselves as independently as possible. And in OT, you may have seen people come in with these splints on. Those are silver ring splints. They allow you to flex, but you can't hyperextend. They are very useful, although people keep getting bothered on the street by goths who think they're jewelry. Like, hey man, where do I get those? No, these are medical, go away. We give them adaptive equipment and help them with joint protection and edema control, other kinds of splinting when needed. Standard lifestyle suggestions. There is no particular EDS diet. There's no indication to eat collagen, because you're going to break it down and build it into whatever you have anyway. Not all the EDSs are even collagen defects, but people should hydrate lots. They may want to drink electrolyte supplements. Standard advice for irritable bowel syndrome and bladder irritability. We don't have any good data for acupuncture. Mindfulness and daily relaxation can be really helpful. Medication-wise, very briefly, we kind of have the standard stuff. We don't have any brilliant meds for this. And just as in the non-EDS population, NSAIDs may help, antidepressants or anticonvulsants where the situation warrants. Lots of these folks fit fibromyalgia criteria and will respond to low-dose pregabalin or gabapentin. They don't tolerate tricyclic antidepressants very well at all if they're orthostatic, but sometimes the SNRIs are helpful. We really don't recommend opioids because of all the problems they can cause. Muscle relaxants, generally short-term only, although some people will use baclofen or tizanidine. No solid data at all on cannabinoids, although we sure have a lot of people who are popping them. They don't seem to have any trouble getting a hold of stuff. Low-dose naltrexone, does it help? Sometimes. That's all I'll say there. Should we get genetic testing? Probably not. We don't have a reliable marker yet. Once we get one, we might start using it. But generally speaking, whenever you send off a test battery, there are 3 potential results. Negative, which means, hey, it's probably hypermobile EDS. Positive for another EDS, which is rare, or a variant of uncertain significance where, hi, you have a change in a gene, we have no idea what it means, sayonara. So a lot of people don't like to live with that uncertainty. So while some people do benefit from some genetic counseling if family planning is involved, I don't send off a whole lot of genetic testing. When do you call me or the legions of people I'm trying to train? Please, God, get into this quickly. If initial efforts are not working, if the treatment goals aren't being met, if the pain is still poorly controlled or function's not improving, if the issues just plain are beyond what you feel comfortable with, or if the diagnosis is in question and you need some more help, I'm here and happy to work with you. If I don't know the answer, I'll try to point you to the place to get the right one. And lastly, we've got the link again, and I will go ahead and put that into the chat right now while we're thinking about it. I thank you so much for your time. I realize it's a whirlwind worth of stuff in a very brief time, and I hope that you found it to be useful.